Administrators did not want to buy that equipment for the simple reason that the last thing they wanted was more patients coming to our hospital because we had this wonderful expertise. Many of them are suffering and dying as their cancer spread on wait lists. And the public is denied that data. The economic costs of wait lists in just 4 categories in 1 year was $14.8 billion in Canada. So this is a massive drain on the economy, but it's also causing massive suffering to patients. What idiot bureaucrat would write such a policy? And she said, well, I don't know offhand. And I said, well, there is no such policy, I don't think. And she said, yes, there is. I'll go and get the book. So she went and got the book of policy, hospital policy manual, and she starts reading it out. And I said, that's ridiculous. What dimwit wrote such a thing? And she says, well, it's signed Dr. Brian Day, chairman of the arthroscopy service. 100% of our nurses enjoyed the work and would recommend the facility. An independent survey was done at Vancouver General Hospital asking nurses the same question. 25% of nurses would recommend their facility.
The Titanic is sinking. You have lifeboats, and the lifeboats can only carry a certain number of people. And you and I are here saying, look at all those people who are drowning. This is terrible. And the government is arguing, no, on average, we have a whole bunch of people in the boats.
This is bizarre. Like, it is bizarre that, to repeat, that we are the only country on the planet where private health insurance is illegal.
Concepts with Shawn Whatley.
So I have a really exciting guest, Dr. Brian Day, and we'll be talking about his book, My Fight for Canadian Healthcare, a 30-year battle to put patients first. So Dr. Day started out in Vancouver. He started his training in Vancouver in 1973. At that point, medical practice was in its golden era that had been built up over really 300 years. The first hospital in Canada was 1639, Hotel Dieu in Quebec City. And then in 1968, Canada got Medicare, or state medical insurance. And that rolled out across Canada between 1968 and 1972. So Dr. Day started his training in BC, 1973. He was able to experience the norms and the cultural expectations and behaviors within the profession of medicine itself that no longer exist today. When he first got out into practice, he would compete to take extra on-call hours so that he could operate more at night in order to build his practice. He had to compete with other specialists to get patients. Family docs also had to compete with other family docs, or they might lose their patients. So within that environment, Dr. Day had the experience of no waits, operating on patients, many of whom had no insurance coverage at all. 30% of his patients at that time still had no coverage because state health insurance was optional for the first few years in the 70s. But in those 20 years or so, 1973 to the mid-90s, when he started working on Cambie Clinic, he published over 200 academic articles. He's lectured around the world. He's a sought-after international expert. And yet none of that comes out in the stories that you hear about Dr. Day. Mostly you just hear about Cambie Surgical Clinic and how Dr. Day is, in fact, using the words of former Minister of Health in Ontario, George Smitherman. He referred to him, I believe, as the Darth Vader of Medicare. In all of this, Dr. Day has maintained a sense of hope and a willingness to laugh at himself and a healthy perspective on what's really important. So thanks again for dropping by. I hope you enjoy this discussion as much as I did, and looking forward to hearing what you think of it. Welcome, Brian.
Thanks, John.
It's great to have you here. I absolutely love your book. If anyone is watching this and you're only watching the first 2 minutes of the video or the podcast, go out and buy this book. It's fun. It's full of great stories about, mountain goats being operated on and escaping in the hospital, and Dr. Day meeting Fidel Castro. It's just fantastic. And I wanted to start, Brian, with your recollection of your early days in training. So you came to Vancouver in 1973, and I want to read part of a sentence from page 10. You said even after qualifying, you would volunteer to take extra call as a way to build up your practices. Quote, since there was no shortage of general practitioners or specialists, and as young surgeons, we even competed for referrals, end quote. So I wonder if you could give us a sense of what medical care was like in the 1970s, because today we often conflate medical care with Medicare. And I'm wondering if you see a difference between medical care versus state insurance, especially in the 1970s.
Yeah, so I mean, I think the biggest difference was that there was no shortage of doctors. In fact, we were ranked between second and fourth in the world in doctors per population. The Index Mandi recently ranked us 76th in the world. And so there was no shortage of doctors, no shortage of nurses, there was no shortage of hospital beds, and all of those things were cut back based by government policies. But the main thing, in answer to your question, what we had to do was build up a practice. And so specialists had pretty well unlimited operating time, but there was no there was no shortage of specialists. So and there was no shortage of family physicians, so you could go and see your family doctor, get seen by a specialist within a week, and you had specialists wanting to see patients, wanting to get them into hospital, and the same with family physicians, and things worked really well, even though a lot of patients didn't even have medical coverage but they all got treated.
Yeah. Yeah. So you mentioned on page 12 that as for access and coverage, up to 30% of patients did not even have medical coverage when I started practice, but all received care, and we treated those without coverage at no cost, end quote. And then a few pages later, on page 15, quote, no patient was denied care due to insurance status, end quote. And so as an orthopedic surgeon, I want you to, feel free to dilate on this a little bit. Tommy Douglas used orthopedic surgery as the main story. So everybody has heard, or if you're in this space, healthcare space, we've all heard about Tommy Douglas's leg. He had osteomyelitis, an infection in the bone as a kid in the early 20th century. He was actually in Children's Hospital in Winnipeg for 18 months, multiple surgeries and specialists seeing him. And eventually the orthopedic surgeons just said, there's nothing more we can do. I think we're going to have to amputate. And the way Tommy Douglas tells the story is he said, well, because my parents were poor, they couldn't afford the best surgeon. And so a doctor came by who said, listen, if you let my students observe the case, I won't charge you anything, but I want to try something. I want to try to do something and save your son's leg. And Tommy Douglas paints this out as being, well, there was ideal care. There was a standard of care, but only wealthy people could access that. And really, if you were poor, you were denied the proper treatment. And so the orthopedic surgeons would take off your son's leg. And this is in the 1960s, Tommy Douglas is making this story. And so you started training only 10 years after Tommy Douglas was making these allegations. Is that the medical system that you entered, Dr. Day? Did you ever talk to your colleagues who amputated the legs of poor children?
No, I think that's ridiculous. And Tommy Douglas, if you really research him, he's not the person that people have built him up to be. I think it's on the public record that he got private health care for his daughter, Shirley Douglas. It's in the public record that he did not found Medicare. He was not the founder of Medicare in Saskatchewan. It was, and the Saskatchewan government has acknowledged that, but Douglas took credit for it. It's also on record that Douglas, I mean, to be fair to him, he never was against a state monopoly in the funding and delivery of healthcare. He came out and said in one situation that he thinks that the state should be providing minimum basic care, but you should never stand in the way of individuals seeking options other than the government. So there are a lot of myths surrounding Tommy Douglas, but I don't. That's just basically an attack on doctors and their ethics, and I saw the exact opposite. That patients were treated the same, whoever they were. And actually, I've seen that. I lived and worked in Switzerland for 6 months, over 6 months, and there they have a system based on private hospitals and private insurance mostly. But if you're a low income or poor, so to speak, you get the government pays the private insurance premiums, and you get to, if you're admitted to hospital, you're actually in the same, you're in a room, private room next to a millionaire. So this private versus the rich and poor thing is also part of the Tommy Douglas myth that, and as I say, he used private care for his own family.
Mm-hmm. Yeah, I appreciate you saying that. And the reason I went on a little bit long on that was because he was attacking orthopedic surgeons. You're an orthopedic surgeon. And I think what he said is heinous. Why would a country support a profession that amputated legs that could otherwise be saved? The basis of medicine is save life and limb. But
to be fair, though, orthopedic surgeons are used to being attacked. As you might imagine, when I was CMA president, I spoke at meetings across the country, and I remember once they often would introduce me, because they were not orthopedics, with an orthopedic surgeon joke. And one of the ones I remember in I think this was in Manitoba Medical Association. They said, well, we're going to introduce an orthopedic surgeon now, Dr. Brian Day. And I'll just tell you a fact. This is the introductory comment. There were 2 orthopedic surgeons who were doing a jigsaw puzzle, and were very proud that they completed it in just 55 hours. And so, well, why would you be proud of that? They asked the orthopedic surgeons, why are you proud of 55 hours? He says, well, on the box it says 2 to 3 years. But I'm used to that. I'm used to being attacked. Yeah.
Well, that's very.
And then I have to go on and give a talk, with in ridicule. But that's part of the game of being an orthopedic surgeon.
Well, certainly you've embraced that. You've leaned into that because you just go ahead and tell jokes. There was one brilliant story. Maybe you could just tell it right now, where you were in the operating room and you couldn't get access to a particular piece of equipment. And you said, who is the moron or whatever who wrote this policy that says I can't get access to this piece of equipment? Do you remember the story? Yeah.
Yeah, I wanted to do something quite different from, quite different from what the normal policy was, because I thought it would be better for the patient. And I said, I want to use this equipment instead. And the head nurse said, no, you can't use that. I said, and this was, I said, well, why not? She said, well, it's against hospital policy. And I said, what idiot bureaucrat would write such a policy? And she said, well, I don't know offhand. And I said, well, there is no such policy, I don't think. And she said, yes, there is. I'll go and get the book. So she went and got the book of policy, hospital policy manual, and she starts reading it out. And I said, that's ridiculous. What dimwit wrote such a thing? And she says, well, it's signed Dr. Brian Day, chairman of the arthroscopy service. So I had to bite my lip. And so, as I say, I run down hospital bureaucrats, but in some ways I was once one, and understand how things work.
Yeah. Well, I love that story because it speaks to your whole personality and willingness to lean in, poke fun at yourself. And but I'll have to say that there's a weakness with that, Brian, because I think you don't toot your own horn enough. And this is something that I like to emphasize whenever I get the chance to introduce you or to tell people about you. I say, listen, this guy has over 200 academic articles published. He's been he's the president of the Canadian Medical Association. He's president, I believe, of the Orthopedic Association. He's international speaker. You basically give televised broadcasts of surgeries to academic conferences. They can watch people doing procedures at Cambie from around the world. So you have demonstrated success in academia long before you got into this whole Cambie clinic
Well,
story.
there's a relationship, Shawn, because my colleagues and I, we would travel and go to conferences as you did as a physician also, and you get exposed to the latest, greatest technologies. And of course, what we found was we'd see this new technique or instruments that made the surgery less invasive and with a quicker recovery for patients. And we would want that equipment to treat our patients more efficiently and with less trauma. But under the health funding system of Canadian hospitals, the administrators did not want to buy that equipment for the simple reason that the last thing they wanted was more patients coming to our hospital because we had this wonderful expertise. And that comes down to, as you know, comes down to the funding system of global budgets or block funding for hospitals, whereby uniquely in the OECD, we are the only country that operates on block funding, which means the hospital gets its money upfront every financial year, and therefore every patient is using up the hospital's revenue. It means that every patient is a cost item, whereas in other countries, like every other OECD country, when patient goes to an emergency department, when a patient goes to becomes an inpatient for surgery, the hospital receives government from the revenue. And I'm talking about the public system. They receive money from the public system and are therefore rewarded for treating patients. So emergency departments that have long wait lists in those countries suffer from lots of revenue. And therefore, the hospital wants the emergency department to be efficient so that it attracts patients, the exact opposite of the situation today.
Yeah. Yeah. And that leads into something you say here on page 18. You say between 1981 and 1995, the scheduled operating time allotted to each surgeon at UBC, so the University of British Columbia Hospital, was progressively reduced from approximately 17 to 22 hours to about 5 hours a week, end quote. And then on page 39, you reference the Canadian Orthopedic Association as saying 13.5 hours weekly is really the minimum that a surgeon should be operating to maintain skills. And so that decision to reduce your hours, is that still the case, or was that just a minor blip in the 1990s?
No, it's still the case. And I mean, you know what happens now is that patients, there are three barriers now to access. There's the barrier to see a family physician, because in Canada you need a family physician's referral to a specialist, or an emergency physician's referral to a specialist. And there's that barrier. Then there's the barrier of waiting. So first of all, the barrier to see the family physician is there. Then the barrier from the family physician to see the specialist, and then the long time from seeing the specialist to being booked for surgery. And we know from data, government data, that patients are with serious cancers are waiting and dying. Many of them are suffering and dying as their cancers spread on wait lists. And the public is denied that data. We have that data from our trial in the 2017 data, which the government tried to stop us from getting, but we had to call a government hostile witness from the government to get that into evidence, that something like some of the cancers with serious risk of progression, 13% or 16% were being treated in the maximum safe time. And this is unacceptable. And of course, you are forced into that position by the laws of Canada. You cannot, there is no care guarantee, there is no choice, there is no appeal. And of course, the other thing I like to point out is low income groups, the poor, they have the worst access and the worst outcomes, because the so-called wealthy, a lot of them head off to the United States. Like 217,000 a year was the last figure I saw of Canadians each year going to the United States.
Yeah. So you're ruining my perfect plans of how this interview is supposed to go. No. This is brilliant.
I've got flight of ideas.
Yeah. No, I know this is fantastic. So you mentioned the 16% number, which is impressive that you pulled that number out of your head with a page of over, book of over 400 pages. That's on page 211. You say this, quote, in 2017 to 2018, only 16 to 38% of patients in need of treatment for serious cancers of the bladder, ovary, prostate, lung, and colon were being treated within the maximum acceptable time. And then you go on to talk about that more. So I thought, I was cheering. This is fantastic that you were able to even get that data. I was surprised that the data even existed. And not, it's a heinous number, but I was also surprised that the number existed and that you were able to get it. So congratulations to you guys for doing that.
But we haven't been able, they won't release subsequent years. And I'm sure every province, or nearly every province, has similar data that they hide from the public who rightfully own it and should have access to it.
Yeah. Now, there's a beautiful quote you have here. We could spend the whole time just talking about the current state of the system. But on page 55, you say this, quote, Canada is suffering from a widespread, insidious, ideological kind of hypocrisy and an irrational fear. A system ardently defended on the grounds of equality and equity actually favors the wealthy, powerful, and well-connected in ways that no market system ever did or could. Many of them know it, and they enjoy those privileges. Well-connected Canadians call their contacts and navigate or manipulate the system. End quote. So strong words. You've alluded to that already. Can you tell me more about special access for the well-connected?
Well, yeah. In 1999, I wrote an op-ed in the Vancouver Sun, which is BC's main newspaper, called The Hypocritical Oath. And in it, so this is not a new concept. And to be fair, it happens the world over in terms of the wealthy and the powerful. I mean, no politician, no federal or provincial minister of anything is going to wait for healthcare. That's life. They make a phone call. And we see multiple examples of that, but there are two aspects to the question you asked. One is where you jump queues based on status and influence, and then and the other is where more the hypocrisy is those individuals that are well known who have access private healthcare for themselves, knowing that that while still preaching that everyone should have the same level of access. So for example, prime ministers like Jean Chrétien, it's in the public record that he used the Canadian Armed Forces jet to fly him and I think his family, but at least him to a private clinic in Minnesota when he needed healthcare. He was an advocate and supporter of a private hospital being built in Beijing, China, by InterHealth Canada, which is a Canadian company with private company, but shareholders included the BC NDP government and the Ontario NDP government of that era. And Chrétien was there supporting it, building private hospitals in other countries and recruiting Canadian doctors and nurses to go. They tried to I was sent a letter of recruitment by a fellow called Wilson Parasiuk, who was the CEO and a former NDP health minister running this kind of thing goes on, but both the founders of the Canada Health Act were Monique Béjean and Pierre Trudeau. Both of them accessed private healthcare after they brought in the Canada Health Act. They were treated privately by a friend of mine, and who's an orthopedic surgeon, and the list goes on. Belinda Stronach, Senator Ed Lawson, these individuals, Robert Bourassa, they all went down to the United States to get private health care. And then the other group are those who are exempt from the rules that the rest of us have to abide by. And that is federal employees, so federal police officers, RCMP, Canadian Armed Forces, federal prisoners, judges. They're all exempt from the legal restrictions on access to healthcare, and workers' compensation patients are the biggest group, and a group like the workers' compensation boards across the country, they understand that it's actually cheaper to treat people quickly. That's the big paradox of this whole thing. And as I like to point out, and I know, I'm giving you information, Shawn, that I know because you've written a couple of books on healthcare. So I'm not. This is for your audience. I know you know everything, so I don't need to tell you.
I don't know everything, no.
Well, yeah, but almost everything. But this is. It's just bizarre that we're in this situation and that patients, Canadian patients are accepting their plight instead of making do. But the main reason why governments operate with this rationing and is that they don't plan long term. That we know, workers' compensation boards know that long term, and they are responsible for your care long term, whereas a government is only responsible for the 3 or 4 years left in its mandate. So governments don't plan for 10, 15, 20 years down the road. And it's one of the points that I make often is Lee Kuan Yew, the founder of Singapore, says, one of the problems with democracy is that the governments operate in 3 to 4 year financial cycles, and that's not good enough. No successful entity can do that, and that's why we just get into greater and greater debt because of the cost of waiting.
Yeah.
When I was CMA president, we did a study that showed, just looking at 4 categories of healthcare, the economic costs, not the suffering and the long-term health costs, but the economic costs of wait lists in just 4 categories in 1 year was $14.8 billion in Canada. That's just 4. Imagine what it would be if you could look at every procedure. So this is a massive drain on the economy, but it's also causing massive suffering to patients.
Yeah, well said. And when you're talking about people getting access to care, I often say that you can try to eliminate the market. Well, the market is just relationships, and the unit of exchange when you go to a grocery store or when you go to your dentist or your lawyer, the unit of exchange in part is money, either your insurance or your Visa card or cash. When we eliminate that in medical care, you haven't eliminated the exchange element. The basis of exchange now is on your connections, how close you are, who you know, how articulate you are, whether you're a lawyer and you're threatening the doctor. So there's all multiple layers of elements of exchange that are amplified now when you arbitrarily eliminate the exchange of funds such that the wealthy, the educated, the articulate, the well-connected, the powerful have even better access than the less articulate, less educated, and that's to me is just heinous. And something there are many things I didn't know that I learned from your book, but something that jumped out at me, I wanted to say, page 31, you said Canada has seen about 450 government healthcare royal commissions and task forces. 450. So I said, that's got to be a typo. I have to ask Brian about it.
Well, it's true that I mean, this is actually, people who write about these commissions say it's a way for a government to deflect responsibility and put it off, put off decision making, and yes, they're actually, I have the list of them all, and it's a way. When you don't want to when a government doesn't want to make a decision, they form a commission to make that decision, whereas politicians were elected to do that. Not, the public didn't create. Yes, you can ask one consultant with a phone call, but to create a commission that goes on for 6 or 9 or 12 months or longer is and experts acknowledge it's just a delaying tactic.
Yeah. So just before we get into talking about the court case, I wanted to just have a few moments to focus on Cambie Surgery itself, so your clinic itself. And there are comments you make here on page 116 and 117 where you talk about, quote, Cambie's work environment and culture are valued by our staff. That was previously the case at our public hospitals, end quote. And then page 117, you talk about the positive stories and some examples of positive feedback you get. Page 119, you've got a picture of an OR circulating nurse, senior medical device technician and an orthopedic surgeon on their hands and knees scrubbing the floor. On the next page, and they're smiling because they just had to get the job done. They said, okay, we're going to do this. No, I imagine that's a rare occurrence. That's why they're smiling, and you took the picture. Another picture, you have your accountant shoveling the sidewalk because he was just anxious to get it done. And now people could spin this in a negative way and say, oh, I can't believe, Dr. Day, you hire accountants to shovel the sidewalk. But I wanted to comment on the culture at Cambie and the positive stories, because really the whole court case has put you on your back foot, where you're defending these terrible outcomes for patients. It seems like everything is kind of negative, whereas really, if it wasn't for the court case and we were on an equal playing field, you'd be saying, look, this is a great place to work. We have low infection rates. We have great outcomes. Patients are happy. Can you tell us a bit of that story, the positive side, the culture, and for patients?
Well, I think it stems back to the, as we alluded to earlier, that everyone at Cambie is respected, number one. Like, honestly, that, and you can survey. Actually, an independent group did it. Accreditation Canada and others have surveyed the nurses and the staff confidentially, and we have, like, literally, I mean, it's almost embarrassing. This group that's called Centers that did it. 100% of our nurses enjoyed the work and would recommend the facility. An independent survey was done at Vancouver General Hospital asking nurses the same question. 25% of nurses would recommend the facility. And it's just that I think, looking at it in a coarse manner, obviously goes back to what we were talking about earlier. Every patient comes into our clinic is a valued customer, whereas the administration in the hospital looks upon every patient as a cost item. And, that filters down. And what's happened in the hospitals is they've become so short-staffed, and that people take it out. Patients take it out on the first-line workers, just like in COVID. You see at the airport that the porters and the booking clerks who are being attacked, not physically, but verbally attacked and abused, because those are the people that they face when they walk into the hospital. And so at Cambie, so we never asked our accountant to clear the snow. He just, Vancouver is not known for its snow clearing ability. And he just decided, I'm going to do it. And the same with what happened with the orthopedic surgeon and the CSD staff person was three rooms finished all at the same time. And so the housekeeping staff were busy, and they just wanted to get on with it because they wanted to just do it. And of course, that couldn't happen in a public hospital. But we have a very good work environment. We don't, one of the criticisms is, the trouble with private system is that you will take nurses and staff away from the public hospitals. Well, that's not true. So even among our doctors, we asked 23 of our younger doctors, surgeons, in a survey. They said they would not be in Canada if it were not for the extra operating time that they were able to access, and for their injured workers and those who are allowed to come to treat their workers' compensation patients and similar patients, that then they can use the limited operating time of the public hospital. So they actually wouldn't be in Canada if it were not for our facility. And the nurses, a lot of the nurses that we have are young nurses with families, young children. They cannot do the compulsory night shifts and so on that they're required to do in the public hospital. So we have the flexibility to say, well, just come whenever you want. We want you. And they do. And so we've actually brought nurses back into the workforce. And I know you know about the Ontario study that showed a few thousand Ontario nurses every day go down to the United States to work because the commonest reason is they can't get full-time work in Canada. So this goes, I know you're getting into the lawsuit, but in the lawsuit, even though we lost the case, the BC Appeal Court recognized that there's deliberate rationing, that the government this is a deliberate act causing this, that wait lists, deaths on wait lists, and so on are all caused by the policies of governments. And of course, with the workforce too, one of the issues we have, and I know you know about this and many do, but we have this massive government bureaucracy where we have 11 public health bureaucrats for every one that Germany has. In BC, our hospital regions have 64 vice presidents. each earning probably over $500,000 a year, more than the premier. And that's money that could be going, and you've heard my quote that I don't know why we need 64 vice presidents of hospitals in BC when the United States gets by with one. But this is a massive cost. And of course, if you're the vice president, you want an associate vice president, and an associate vice president wants an assistant vice president. And that's the way these bureaucracies grow. That's where a lot of the money is going. And it's a self-propagating issue, and we've got to solve it by and I think that's something that that could be done within the public system. A lot of the solutions, as you've alluded to also in your books, can be fixed within the public system.
So, and I apologize, I know it's weird when I've heard so many of your stories, and many of them a couple of times, and I love them every time. You do not have to apologize for telling that. That's why I have you here, because I want to hear these stories again, and I want my audience to hear them as well. So we're pivoting now into your court case, but you did mention that your patients are customers, and so as soon as people hear that, people hear, oh, well, that's because it's so much profit, and certainly that came up in the court case as well. But a detail that I didn't know, you mentioned on page 196 that you had wanted to get into the as admissible evidence, and it was denied. And we're going to talk about that too, about hearsay and opinion. But you say this, quote, "I had tried to enter documentary evidence that the trial judge ruled inadmissible. An independent audit of Cambie showed that every $5,000 in revenue generated a profit of just $65. That evidence would counter allegations that large and excessive profits were being generated by private clinics. Cambie is not a burden on the system." And then you go on. Can you tell us more about that? Because I didn't know that detail. And I think people are thinking, well, if you drive a Rolls Royce and you spend, $200,000 to get your knee fixed, then yeah, Cambie's great. But that doesn't sound like what you're talking about. $65 on $5,000. I mean, Dr. Day, that's a bad business.
Well, yeah, and it wasn't. One of the interesting things about how we started was we actually thought we might be able to get a non-profit approval, private non-profit, because we weren't in it for profit. Some of our founding shareholders had donated literally hundreds of millions of dollars to the public system. Like they've got pavilions and buildings named after them. There's a new massive St. Paul's hospital being built in downtown Vancouver right now. The land on which it's being built was bought in trust by two of our shareholders 25, 30 years ago for $20 million. And it's now the land was worth well over 500 million, maybe closer to $1 billion. They recently sold it to the St. Paul's Hospital for the $20 million that they bought it for 30 years ago. Wow. And equally, so this was not set up to make a profit. It was set up because we wanted to stay and work here, and we had no operating time. And so we've always had to stay in the black because you cannot operate as a private facility. We couldn't get private nonprofit because it would have required open government approval. Even so, but we still opened with the quiet support of the BC NDP government at the time. This is an NDP government that in theory was against private healthcare, but they did recognize that something had to give. And I know that in Sweden, private healthcare grew under a socialist government, and it's often the way And I don't think it was anything to do with the fact that I used to play tennis with the premier. I don't think that was related, but may have been a small factor. But basically, we were told, look, go and build. We won't support you, but we won't close you down. And so we set out and we figured out. So we've never generated a massive profit. Like in 7 or 8 years now, there have been no distribution of any dividends to shareholders. They've only they only stay. Well, there's no way they can sell their shares because there's no market for them. So they're stuck. But they're still okay because the land and the building, the land on, what's happened in BC real estate over the last 30 years since we bought the land was that it's gone up in value. So the value is still there. So, but yeah, it wasn't built as a profit center, and it regularly loses money. But we keep we've not had to sell it yet. But a lot of private facilities in BC have closed because of the government restrictions.
Sure. So you have almost 200 pages just about the court case, and there's no way we can talk about it all. Page 166, you talk about, quote, up to 300,000 documents. 300,000 documents were released literally, right before you're supposed to go to trial, or at least that's what it sounds like. So can you tell us a bit about your overall impression of those years? It's very frustrating for me to read. I don't know how you still are smiling after having gone through all of that. But yeah, tell us a few stories. And if you can't think of some, I've got a whole bunch of quotes I could read for you. But what is your overall sense of that trial?
Well, it made one wonder. Okay, on a big scale, I'd say the final outcome, as you know, was we didn't get to. We had previously been interveners in the Charlie case, and it's my opinion and the opinion of many others that if we hadn't intervened, Charlie case in Quebec in 2005 would not have been won, because we took to that case a few of Canada's top lawyers, including our local lawyer Marvin Storrow, but also Peter Hogg, who was Canada's leading constitutional expert that the Supreme Court of Canada would defer to. In fact, Peter Hogg, our lawyer in the intervener, he was the person that swore in new judges at the Supreme Court of Canada. And I remember when we went to the Charlie case as interveners, the lawyer for the Senate came up to us and says, the very fact that he's sitting in your camp is going to influence those judges. And I'm sure it did. And Peter Hogg, sadly he's died now, but he had been brought up in New Zealand and understood that this was not the end of first of all, even though he was looking at the law, he believed, and I still think this is true, that the Charlie decision was binding on the rest of Canada, but it has never been ruled as such, because they ruled on the Quebec Constitution, which is almost identical to the Canadian Constitution. But we went to trial after a very long process. The constitutional challenge began in 2009, and then the trial didn't begin till 2016. There were lots of blockages, and in my view, the government was simply trying to make us go away by raising the costs of this litigation. But we did go to trial, and it went through 194 days in court. The Shawn case took less than 6 weeks, and ours took from 2016 to 2022. So that's how ridiculous the government was in blocking us, in trying to stall us, in trying to make us go away because we couldn't afford. I mean, we didn't pay for all of this. We had lots of support from across the country, donations through the Canadian Constitution Foundation. But, you know, in the big picture, what the fact is we lost at the 2 lower court levels, which didn't surprise us, because the Shawn case also was lost at the lower 2 court levels. And that is the way, that is the way of lower courts. They don't have the confidence to take on their employer. I mean, they're employed by the government. My big take on this now is maybe the courts shouldn't be ruling on government. It should be an independent tribunal of maybe lay people that get advice from lawyers on what the law is, because these we found the BC Court of Appeal. So the lower court judge, in my opinion, was just not qualified to hear this case. He repeatedly forgot things. He repeatedly made errors, and the BC Appeal Court identified many of those errors, not all of them. I mean, one of the classic things that I talk about that the lower court judge said, we tried to point out to him that some expert that the government had brought in pointed out that in Australia subsidizes the premiums, like I suggested that we could do here. Australia subsidizes the premiums for lower income groups, and the government embraces private insurance, just like the Swiss and the Dutch do, for their public system. And so what this expert says, there are parts of Australia that have the highest incidence of private insurance also have the longest wait lists, and therefore there's no evidence, therefore, that these public wait lists are likely caused by, and we tried to point out that says no, this is a correlation, not causation. The judge in the lower court, Justice Steve, said, well, yes, but I find that it's a very strong correlation, therefore it's a causation. And, as I wanted our lawyers to say, which they didn't, was, my lord, there's 20 times more you're 20 times more likely to own an umbrella if you live in Vancouver than in Palm Springs. But that's a very strong correlation. But umbrellas don't cause rain, but they wouldn't do that. But even our trial judge wouldn't have understood that. I don't think. He was not too bright. Then at the BC Appeal Court, we were more shocked because they recognized a lot of the things. They overruled the lower court judge in many vital areas. Like they came out and said that wait times are caused by government rationing of healthcare. They actually came out in their judgment and says that the system is intentionally under-designed to achieve fiscal sustainability, and that that act causes patients to suffer and die on wait lists. They actually came out and said that. And they said that, they also said that we are upholding the provincial law, realizing that this is producing real hardship. And we're not examining what would be an efficient or effective health system. That's not our job. Now, really what they were saying, in my opinion, is we want the Supreme Court of Canada to do this as they did in Shawn. And of course, for no reason given, the Supreme Court of Canada refused to hear the case, despite the fact that statements like that were made, which were not, there were no such statements made in Charlie. And of course, I call this cowardice. I call it cowardice, that the Supreme Court of Canada, whoever, and we don't know who decided not to hear it. We don't know how many judges. They don't give you that data. But the Supreme Court of Canada has refused to basically opine as to whether it's wrong that citizens who live outside of Quebec shouldn't have the same rights as those who live in Quebec under the Charter. So to me, the Charter of Rights and Freedoms now is under serious threat, because we have, no individual whose rights are threatened can afford to fight the government, because the government has unlimited funds with which to challenge you. So, it comes back to saying that there's no point really in having a Charter of Rights and Freedoms.
Yeah. Yeah, you end your book actually with a list of 6 questions. You say, is it right that patients in Quebec have different access or different rights than BC? Is it right that a province can promise care and then not deliver it and outlaw citizens from accessing it somewhere else? You also mention page 306, a number of places, 1, 2, 3, 4, 5, 6 places where the appeals court admits that harm is happening to patients based on this system. And it struck me that it seems the court was, to your point, arguing, or maybe you didn't say this, I apologize if I'm putting words in your mouth, but it seemed to me that the courts, or the government, especially in the courts, agreed, was arguing for average. So on average, this is what we do. And, oh, by the way, a few patients fall through the cracks. And it speaks to your earlier comments about a fundamental misunderstanding about what emergency services, what medical care is all about. We exist at the margins. We exist for the people at the tail end of the curve. And the example I always use is the Titanic is sinking. You have lifeboats, and the lifeboats can only carry a certain number of people. And you and I are here saying, look at all those people who are drowning. This is terrible. And the government is arguing, no, on average, we have a whole bunch of people in the boats, and you're being heartless and cruel for even mentioning about those people who are drowning. So do you think...
In order to be equitable, we should actually let the whole group sink to the bottom of the ocean, and then it would be equitable, equal anyway, not equitable. Yeah. One of the things I think I know you know this, but experts at our trial, both government experts and a government expert and one of our experts, confirmed that of all of the 196 or so countries on the planet, there is only one country where private healthcare insurance is banned, illegal, and that's Canada. That to me, that is the most one of the most significant points to make. How can we be the only country that's got it right, and yet we're the country with one of the rich countries, we're one of the worst performers?
I wanted to ask you, I used to think this was just about ideology and people being blind, but after reading through your several hundred pages on the experience at trial, I came to the thought that maybe people don't have the capacity or they need a better education to understand the difference between average and 90th percentile. Or you used the beautiful example of, dogs and cats. The philosophical fallacy is affirming the consequence. So if you say all cats have 4 legs, there's an animal with 4 legs, therefore it is a cat. Well, that animal could be a dog. So when you affirm the consequent, you are committing a philosophical fallacy. And many times these concepts came up in the trial, and it seemed like the trial judge was not able to understand the fundamental concept being presented. So do you think it's actually an issue of ignorance and not simply ideological maleficence that we're looking at?
Yeah, I mean, it's funny. I was at dinner. I saw a judge at dinner the other day, and I pointed him to, and I think I quote this in the book. I pointed him to the Peter Cook. I actually sent him the Peter Cook, who was a British comedian. It's available on the web, and on judges, and it is pretty derogatory about judging, but judges are like doctors. Some of the doctors are smart, some of the doctors are stupid. Same with judges, and I think that that's the reality of life. And I don't, and I point this out. I mean, some of the smartest people I've ever met are carpenters and plumbers, and some of the most stupid people I've ever met are doctors and judges. And so that's the way the world operates. I'm afraid. I'm not afraid, but that's the way the world operates. That we are not. And I think that with respect to our trial judge, he was out of his depth. He just didn't understand the constitutional issues. He didn't understand simple elementary arithmetic and simple logic, and that was the unlucky part of it. I mean, I was at a recent birthday party for a senior lawyer, and there were 8 judges there. All of them expressed dismay at the trial decision, and at the and some of them were former appeal court judges, and at the fact that the Supreme Court of Canada refused to hear the case. Mm-hmm. So it's something that it's like everything. It depends which doctor you get. Sometimes it depends which. One of the things as you hear, there was actually a recent article in the Canadian Medical Association Journal on one of the solutions for access to surgeons is to go and see the first available surgeon. And I my answer to that is, on Valentine's Day, would you want to go to the most available restaurant that you could book, and it was empty on Valentine's Day? And that's, there are surgeons that you would not want to operate on you, and they're available.
Yeah. And you had another great line. I believe it was from a CBC interview. Colleen Flood was speaking with the CBC. She, I believe, is dean now of the law school at Kingston, so Queens. And she said, well, lining up for a medical procedure is just like lining up for an amusement park ride. And I thought, wow, this is someone who's published extensively. So we're running out of time. I noted on page 299, you told a journalist, quote, "I regretted starting and speaking to the case, but yet you still have a smile. I see you telling jokes. I see you on meetings. You're still involved in this space. So I want you to tell us, how have you maintained strength and resilience, and where is your mind going now as you're thinking about the next 10 years, 15 years? What keeps you awake at night, or what gives you hope? So I've given you a whole bunch of opportunities to say something, but I want you to end with a message of hope. If there is any hope, hopefully there is, but you're still smiling, so there must be some hope there somewhere.
Well, I still, I know that if I live long enough, what the reality is going to be that we change, as I say, there's more to my life than Cambie Surgery Centre, but it's been frustrating. But you have to keep things in perspective, and I think that there are other issues. There are other important aspects to one's life. I think that as the end is going to be the change. Like this has to happen, and eventually the public will demand it. And one that it is now in the hands of the public, because I don't think there can be another. The politicians have washed their hands of it. They're afraid of it. The law, the legal, the judges and the courts have washed their hands of it. They're afraid of it. And so I think it's up to the people now who are suffering at this under our health system to recognize this is bizarre. Like it is bizarre that, to repeat, that we are the only country on the planet where private health insurance is illegal. It's something that Tommy Douglas never believed in, even though I'm not a big fan of Tommy Douglas. It's something that as I say with the hypocrisy thing, we have people who are really enthusiastic supporters of Medicare use private healthcare. I mean, Jack Layton, I forgot to mention Jack Layton went and had his hernia done privately. He tried to tell me once, it was under a public scheme, and I said, no, I know El Shouldice at the Shouldice Clinic where you went, and he told me he has if it ever goes to court, he has your visa slip. I said, so he shut up about it then. But this is the way it works, and this is the reality. There's hypocrisy out there. I said it's now over 25 years that I wrote the hypocritical oath. I think I should ask the newspaper to reprint it because nothing has changed.
Yeah. So I liked what you said. There's more, that you have to keep this in perspective, because I know for even my own short battle of the last 25 years of just being aware of it takes you about 15 years to figure out what's going on. And then I think, gosh, it takes me 2 decades to work this out, and I'm living in this space. What hope is there for the Canadian public? Well, part of the hope is going out and buying this book. This is just really well written. My Fight for Canadian Healthcare, a 30-year battle to put patients first. It is super readable. You don't have to be a master's in public policy or anything. I'm going to have a link in the show notes. If you've made it this far in our episode, please like and subscribe and share. Check out Dr. Day's website. I believe it's brianday.ca. Is that still active?
Yeah.
Yeah, tons. Yeah, no, but there's a ton of resources there. You've got an article in Maclean's coming out soon. Brian, thank you for everything you've done, everything you're continued to do. Really, you're an inspiration to so many of us, and can't wait to see what sort of things you do next to poke the bear. So that's great.
Thanks, Shawn. Thanks for everything you do.
Appreciate it.